Yo, here we go. Week two. Today is November 25th of our Megamind group, our mastermind group of just clinical excellence here. Rainey will be leading this case study today. Let's hear it out, Rainey. What do you got? What do you got for us?
All right. I am pulling up I have a slideshow. I picked a case study that I thought would be interesting. Being in a small outpatient clinic, we get a lot of different patient presentations, but one that's been most challenging for me, um, ACL, knee injuries. This patient is somebody who's been on my mind a lot, learning a lot from, and figured this would be good to share because think we can get a lot from other PTs' perspectives. ACL is definitely a common injury that we'll see um, in athletes, in non-athletes, and can definitely have a big outcome and affect outcome of our health, wellness down the road, depending on how the plan of care or physical therapy is delivered. So yeah, let me share my screen really quick.
Oh yeah, he has the power. Nice.
Got
He's
it.
got the power.
He's got the power.
Can you see that?
Yes, we
Yes,
can.
sir.
Okay, cool. So our case study is a 20 to 30-year-old male volleyball player, status post, a ACL reconstruction. Background, they came to the clinic in early 2024, came in, had had torn their ACL maybe like a month earlier, playing volleyball. And at this point, they are in the mid-stage rehab. They are looking to get back into recreational volleyball, playing with the club, and just getting out playing with their friends. Maybe a little bit more background. They've been playing volleyball for a long time, not had any significant injuries. This was kind of just like a learning curve for both of us. Past history, they had some right knee pain, tendinopathy. So that is common when you see that. You'll see that in jumpers, volleyball players. And my role, pretty much delivering PT. They kind of came in 3 times a week for a long time, and then kind of moving it down to 1 to 2 times a week, which at 8 to 9 months is like 1 to 2 times a week is pretty lucky. I don't think there's a lot of patients that can get. I mean, depending on the insurance, I think that 1 2 times a week is excellent. Moving down the frequency, just trying to increase our independence.
Wait, so you saw them for a late stage rehab? Not you didn't see them early rehab, like status
No, I
post,
did.
like
I
you
saw
mean.
them
Oh, you did.
early in the rehab, so I've seen them through their entire care so far. Because
Hmm.
we have not really entered the point of return to sport. We're not quite to the point of like, hey, let's do a little bit of volleyball. Uh,
Hmm.
Mainly trying to get them running right now. Done. This is just kind of the section where I want to summarize what we need to get and to achieve before we say discharge, and they can go on doing things on their own. Which for both of us, for us, I want my patient to be independent, doing the things that they love, and for my patient, that they feel comfortable, confident, doing everything that they're doing before. To get there, this is maybe an oversimplification, but I think the main things I wanted to see, we call a quad index. Um, that's just saying they're ideally, we want to get their affected leg, to be as strong as the other leg. Their quad, that muscle being really important for ACL and just preventing injury. So I'm in love with this stuff. And maybe I'll go on a quick tangent, but body weight to torque, I've been learning a little bit about how that could be another important measurement to see if they're um, also strong relative to, if they have the strength relative to their body mass. If they're jumping or if they're cutting, decelerating, can their muscles support the force or demand of the task? Um, yeah, we have a crane scale. We've been doing a little bit of testing. It's all very new to me, but any questions on that?
You do this in clinic.
We have a crane scale. It's like a $50, like off of Amazon. Just like have them do. Yeah, I really just use it for like quad testing.
Oh, that's pretty
What
sick.
unit? What unit does it measure? Is it in pounds?
We get kilograms, pounds, and newtons or something like that.
Yeah, because we have a Milwaukee, and yeah, we should be calculating torque to body weight ratio, but I haven't like really sat down and like dug out how to calculate that. So if you have any resources, send them my way, man. I
Mhm.
like that's that. I mean, my understanding is that's the best way to measure the number because you're like you said, you're considering their strength relative to their
Yeah,
weight. Because if they're weak on the
yeah.
other side and they're weak, that's not a great. It's I like the idea of it for sure. Not that I know a ton about it, but
There's some good resources. I definitely feel like it was, depending on how often you see an ACL, I think this is like not every ACL is going to need that kind of number because, like, if they're performing well with general other tasks, so like they're jumping, they're squatting, like you might be able to do without that. Um, but as like a way of digging into some more data to actually see if they're, I don't know. It's helped kind of give me a little bit of a clinical decision making of like, are they ready to start this next tax? Because yeah, like Matt said, after ACL, like one side, their affected side might not be strong, but the other side may not be strong either. So that quad index might not be a good marker of helpful, but like it's determining are they ready to get back to those higher level activities. Does that make sense? Sports battery, hopping, single leg landing, test. That was very oversimplified for volleyball. I mean, there's so many different types of reacting that I'd love my patient to do. Um, but that's in basic something I want to make sure that they're looking strong with. And then running, sport specific jumping. Okay, needs analysis. Very okay. This is a lot of jargon in here. Well, I'll try to break it down real easy. There's four things that I wanted to see. Do they have the strength? Do they have the mobility? Do they have the care like the sport specific characteristics? So are they explosive when they're moving? Jumping, bounding, diving, running. Those were some things I looked into originally when this is a I did this case study a while back and just kind of rehashed it now. Energy demands, they do not have they fatigue quickly with running and a lot of the other exercise, which I think as they get back into playing sports, that they'll be able to develop this. But that was an area that if they're playing volleyball, they're going to get fatigued. I want to make sure that they can play with some fatigue and still maintain like good form. I guess is like a way to like putting it. Decreasing risk of injury, like if they're playing into multiple rounds of volleyball, how are they doing? And that yeah, talk about that. Fatigue resistance with the ability to perform multiple max effort bouts. Um, questions?
I think, dude, you got a space to do all this in your clinic?
Not really. It's we make do, but
Yeah,
it's not perfect.
dude. Like,
We have it's a smaller clinic. We got if it's on a busy day,
mhm.
I don't have the space to do the plyometrics as much.
I guess
But
I,
I can also program. I can program for my patient to do this outside of the clinic a little bit on their own.
yeah, I always I've always like struggled with creating space. I'm completely unrelated to like this, but like I've struggled with creating a space to do things at the gym, right? Because especially if I'm trying to look at acceleration, decelerations, right? Like it's very hard to kind of find the space unless we go outside. But anyway,
No, I agree. I've tried to take my patients outside, and that is definitely an area I have not mastered yet. And I would love to. I've tried to practice working with actually other ACL patients. They've been the only other patient that I've. That's the only patient that we've gone outside when it's nice out, just see how they do with that.
Yeah, space is huge for that population. Yeah.
Okay, current needs. This is from objective testing. There is no numbers here, but we need quad strength. We need to develop leg strength or lower extremity. Again, other hamstrings, glutes, calves. Uh, kind of testing both sides, but also just kind of we're doing a lot of single limb and double limb strengthening. We need to work on deceleration. Um, they, yeah, ballistics, plyometrics, and running. Questions?
So like a month ago, they were 70%.
Okay, yeah. Their last measurement for the quad index was just over 70%. And so that's when we said, hey, let's get running. I've seen a lot of different numbers for that. And we get the okay from ortho to get them running at like 4 or 5 months. But I mean, I don't know what you guys think.
I
There's,
am I struggle with this, man, and I think it's just me, right? Like, for example, I have a patient right now with um, ACL repair, post-op ACL. She's only a couple of months, not a couple of months, couple of weeks, and the protocol says only 90. Don't go past 90, right? Don't do anything past 90 until 6 week. Sh- they have their range of motion, like full extensions, already 100 and something degree flexion, already measured by their surgeon, and I am at limited to just doing things that are very simple. And I know that it's such an early stage of rehabilitation. I struggle with that a lot, trying to when is too early, when is too late.
Wait, is it 90 degrees in like closed chain?
Um, 90 degrees in general is what they. I know
Is it meniscus? Is it meniscus too?
it was meniscus too, yeah,
Oh, yeah,
meniscus,
that's
and
why. Yeah. You
yeah,
want to watch.
yeah,
You
and
want to
so
watch the
which I
extension.
understand the the guidelines of it and saying like you don't want to re-injure, let the meniscus heal, and things like that. So I don't know, man. I struggle with like when too much because I know they said like I just pulled up a Mass General ACL rehab protocol, and just this is just for ACL rehab, and they say you should be transitional state in like 9 to 12 weeks to early return to sport 3 to 5 months. But
Well, yeah, the meniscus definitely is a factor, and it definitely slows things down, especially from like a range perspective. So that's kind of
yeah.
probably the biggest thing. But yeah, I
But for
mean,
you,
there you
Anthony,
go.
you said not 7 to 8 months. You waited until because that's when it took for them to gain like 70, right, more than
yeah,
seventy
they
percent.
at this point they've shown that with the crane scale, with almost with their exercise testing, like we do the leg press or knee extension, that they're just about that 70% mark with like being able to lift 70% of that weight. Does that make sense?
Yeah.
Okay. 7 to 8 months there. Beforehand, they were under 70%. And yeah, we said no running until this point. We did some jumping, but we didn't want to do the single leg. Just that this is straight line running is what we're starting. Partly because wanting to make sure that I think with running, there's also the risk of like they could be strengthening the knee, but do we find other ways to do the task? There's that question. And then I think main focus, keeping things as simple as possible. Squatting, doing knee extensions, working the quad, getting kind of trying to get them as well rounded as possible. Trying to develop kind of like that, yeah, well rounded, getting that kind of athletic base back, and then getting them back into running.
Could you said you were doing jumping and stuff like that earlier, right?
Yeah,
Okay. Could you have done like a controlled, like, light jog, like, or a speed walk?
it's a good question. I think that they've done that on their own.
Uh,
We didn't introduce like controlled running of like let's do minute to two and then like rest and then repeat. When we did do those, when we did run, do some like run testing on the treadmill, their capacity was right around that like 2 minute mark, maybe a minute and a half, 2 minutes before I'm starting to have knee pain, which makes things complicated too. Not because of an ACL or for the sake of like the integrity of the ACL was fine, but just I didn't want to play around with like what's going to irritate their knee. I have to keep things quiet with their knee. And honestly, 7 to 8 months, like I think I heard that's probably a little bit past that point. Um,
Also, I
but
guess the other question would be like, I know we got the numbers as a guideline to give us like, okay, maybe you should go over this way, but like,
yeah,
was how much did you feel that your patient was like psychologically ready or like wanting to do things, or were there things that was holding them back? Sometimes I know that I had a patient a while back, uh, ACL rehab, high school prior, even after like, ooh, he's back to normal. Because we were doing like high level stuff, and but he didn't want to go back to playing sports because of being afraid of injuring himself, and that's a big part of rehabilitation. So,
sure. The running, they probably were ready to do it like a month or two ago, but we also had identified a couple of items, tests that we wanted to make sure that they could perform and complete. And they understood that, we understood it, that we were just being on the same page of like, okay, can you do a single leg squat to a chair? Could you complete like a single leg step down? So getting them onto a stair or like a standard stair height, and can they control that all the way down, back up, and trying to progress that because like a standard step height, do it easy at this point. Um, maybe stuff like that where they were still being challenged with. That's just an example. I could go on about different kind of movements that they were. Yeah, there was definitely. I guess it could be psychological, but physical too. I think they had a combination of the both. So this is kind of just like just a summary of things that we don't want to do yet and things that we have been trying to push. So red, we're saying we still don't want them to play volleyball or change the direction of sports. Sport ortho or some guidelines might say getting back to sports at 9 months, but seeing kind of like some of the tests we're doing, we see that they're kind of like just getting into running. They could be 12 months to more for volleyball. Hopefully, they're closer to that um, lower end of that kind of spectrum. And then yellow zone of things that we're kind of trying to work through in the clinic, besides just generally getting them stronger, is the reintroducing running, getting comfortable with that, and jumping, getting them strong and or feeling like demonstrating the ability to do jumping on the right side as much as the left side. Green zone and stuff I just want them to kind of go ham with. And we've kind of established a training program outside of PT where they're going to the gym, and there's a little bit of oversight from my end, but also they're getting independent with, I want them to get more independent with like, all right, these are things I need to work on, getting stronger, knee extension, leg press, being a very basic, but like, yeah, your basics. What can we do for strength conditioning perspective? That was another role that I've had to play, and honestly, like one of the more fun things besides your like overview of plan of care as a PT is being also that strength coach. You don't get to do that with a lot of other patients all the time, just because I think length of care. Um, but this patient, yeah, we went out with that. All right. MVP. This is something we worked on through a course project.
Wait,
I
hold on.
really,
Can you explain what
yeah.
MVP is?
So this is a tool that I've learned through my class I took earlier in the year from clinical athlete. MVP meaning minimal viable program. This is like a very, I need to go back to some of the basics, and this could be cleaned up a little bit. But essentially, we're trying to identify the exercises and or the not even just exercises, but what are their needs, like we went over earlier, and creating kind of like these buckets of we need them to have some kind of movement that's going to fulfill this characteristic or help them to develop this characteristic. And then, for example, they need leg strength, so we're going to develop that with the dumbbell squats and the step downs. And they're going to be adequately challenged by doing it with X weight, which at this point, I really just need my patient to, I want them to be able to identify that on their own, but it's something we went more in depth with previously. Um, but yeah, so buckets of needs, and then the characteristics of how we're going to do that. And these are all the kind of exercises we've identified. And these things are going to help us to kind of piece together and achieve our goals, KPIs, our performance indicators. If they can do this is like, all right, if they can do X with the exercise, I need them to be able to do a certain amount. And like, we just kind of said, like at the top, that's our goals. This is one of the first MVPs that I actually developed because with the course, this was our kind of our capstone. And we've been working off of this and kind of revising here and there just to find what do we need that. And then I've been kind of using this for other patients as well, but just kind of a way of showing them that they can progress their home exercise program beyond the 3 sets of 10 and only do like these specific exercises. Like I want them to get, this is something I hope encourages people to get into like doing some exercises that are like in the gym or challenging them, getting the heart rate up or getting like a good like muscle pump. All right, I think that's
Perfect.
it. So I'm sorry that was a lot to process. I mean, I kind of figured this would be a good one to kind of go over, or I think cool for us to talk about, and I hope other people can take away from it too. The There is a lot of jargon in there, and it's something I got to work on. Um, but I have some clinical questions from this case that I think maybe we could discuss, and then I don't know if you guys have other thoughts or like we talked about, maybe just sharing the clinic, your cases as well?
Yeah. Go ahead, man. Fire your questions away so we maybe ponder around and possibly don't have answers to.
All right. So if you have unlimited time with a patient, let's say it's your ACL patient, you could have them be in the clinic with you 3 days a week. But you want to work with them in developing that, like being independent and um, confident in their own self management. How many times do you? This is like I don't want to. Yeah. How often would you expect to see a patient for ACL? They're coming to like end of mid stage, entering that late stage. Like, do you feel like you might see them? Um, I feel like 2 times a week is a good spot. That's where me and my patient have landed on is a sweet spot. I mean, maybe moving to one, but yeah, I don't know. What have you guys seen with your ACL patients? And I know that's like kind of things.
Yeah, so
Everything's
I know what you're saying.
different
So
for everyone.
this far out, like what their frequency usually? I mean, for me, like mid late stage, they're usually once a week, maybe even once every 2 weeks. I think like twice a week for like when they first start. So we're just, and again, not that I've seen a ton of ACLs or so I'm basically referring to like knee surgery, so like that would include like a quad tendon or even meniscus. So yeah, like initially, like range of motion is the focus, right, and then getting quad strength back. So they're probably twice a week to start, but I don't know. I utilize an approach where I encourage them to be in the gym more, and yeah, honestly, like I have some patients that aren't very compliant, and maybe it would be better for them to come in once a week. But I also adopt the mindset of like, hey, you're like this is your rehab, like you need to take ownership of this, and you're either going to do it or not. And yeah, I mean, if they really want to come, twice a week, they can. We can have that discussion. But I do like encourage that,
I
not push, but I encourage, independence. And especially in this stage, like if you put them on a good program, like they could probably go to once every other week. You might want to go once a week first and then to once every other week. I don't know if I mean, some insurance have visit limits. That's obviously a role, plays a factor too. I mean, obviously it'd be great if we could make the decision not based on that, but that's a factor to
yeah.
consider.
I actually I probably come from like a very like I'm very similar thought process as Matt. What you were saying, independence is huge for me, but I also come from like a very different perspective. I think so. Early on in my career, right, I was seeing a lot of. I was at a community health center treating a lot of chronic conditions, and one thing that I realized is that like the more you try to get involved, the more reliant they are of you to get things better and thinking that you may be the reason why they're getting better. And for some reason, to me, that felt wrong, almost, you know, um, unethical in a sense. Because, like, as a this physical therapy profession in general, our goal is to promote independence. And with them relying us to fix things or, fix that we think that we are the reason why that something's happening is kind of I feel like far-fetched a little bit because we're merely a guide really, right? And so I kind of come from that perspective a little bit. So like anytime nowadays, anytime I see patient, I almost make sure to make a point that um, you know, physical therapy happens wherever you are, not with me. I am just a guide, right? To
Yes.
encourage that independence.
Yes, Subash. I love that.
Uh, no, I seriously like for example, I had a patient that I sat there and listened to her. That's it. I didn't do anything. Right? I didn't do anything. I said sat there and listened to her, and this was a while back. And she said, "I was the reason why her all of these issues was solved. I didn't do anything." And now she was saying she didn't want to see a PTA because I was seeing someone else. I was evaluating other patients. She only wanted to see me. It was almost to a point where it got unhealthy because she, even though she was at a point where she could she didn't have any more impairments anymore. But she was still relying on me to fix her. And so kind of that perspective puts, so that's where I come from. Right. And so even with my ACL patient that I have right now, I don't, obviously I want to see her more in the beginning, but eventually the goal is to promote that independence that she could do those stuff on their own. So that's where I come from, which is, I guess, slightly different. But I know that insurance plays a big factor. I know organization mission plays a big role, and like I guess, what they value and what they're trying to achieve through seeing patients. And so there's a whole lot of, like, I guess, caveat to that, but that's
Right.
me.
There's so many resources that are required, and it's so different from patient to patient, like attentional resources to the physical resources of space and or other things like that. And yeah, I hear you, Sebastian. Like when you have those patients that are like you want to be able to, yeah, you want to build the independence and be the guide, but not necessarily want them to develop that that dependence on you.
Hmm.
It's, it's
Yeah,
tricky. Like, for
it
this
is.
for an ACL patient, this is something mutually agreed upon that like, hey, we're going to still do this. We're going to meet 2 times a week. From an accountability perspective, I'm all for it. And even if maybe we don't add a ton to our program, is what our clinic can offer. But it's like, yeah, we're trying to think of like from all right, how do we approach this from most ethical perspective, and like how can we make sure that they are getting the most value that
Listen,
yeah.
if insurance wasn't an issue, if time you could, that was an issue, I feel like obviously having anyone to do rehabilitations throughout this entire process, because which we know that it takes at least 9 to 12 months to like fully be returned, be ready to get back to whatever. Even then, psychological factor plays a usual whether they're going to play or not. You know, so if there was time and interns wasn't no issues and they could come as many times as possible, then yeah, 100%, man, come see me. You know, but while in taking in considerations of, like, dependence, not. But again,
Mhm. Right. That's just an area where my head's been at a lot with this case, and it's a clinical kind of some clinical decision making that we've been playing. So that's one of my questions. And then
I
my last,
I guess I kind of, sorry, man, I didn't mean to cut
no,
you
go
off, but
for it.
like 7 months is it still like, Matt, what's your experience from the like, limited amount of ACLs or things that, like, you said you get, like, what's your usual, like, time frames? What has been your experience?
Yeah, I mean, it depends. When I was a wee little guppy, like this is one of my first patients. The surgeon cleared this person after like 5 months. And it was a um I'm blanking on the term. It wasn't a full reconstruction. They just like sewed the ACL together. There's a term for it. That I'm blanking on.
Bridge
But they
procedure,
cleared him. Huh?
bridge
Bridge?
procedure.
No, no. The ACL had like it was close enough. The guy went in there. He actually took the hamstring graft, but the guy went in there and then like he was able to sew it together. Whatever. Um, but yeah, I've had people that their surgeon clears them really quick, and that's obviously a difficult conversation. But they went back to sport really quick, and then I have another guy who he's further out at this point. Probably a little bit behind where they quote unquote should be based on like a strength perspective. Um, so yeah, it kind of depends on the case. Some people are going to like push to return to sport. Some people are going to be more cautious. It's better for the people who are more cautious, and it's important to set the expectation too. You want to set the expectation on your first visit, like, hey, ACL is a 9 to 12 month injury minimum, and it's important to set that at the start. Whereas, if you just want to be liked and tell them, Oh yeah, we'll get you back ASAP. But wait, you asking what their goal are? Their goals are, oh, I want to get back. Let's say it's now, November. They just tore their ACL. They're like, I want to be back for the spring. You can't be like, okay. You should be like, my guy, that is not
All right.
realistic.
Yeah.
Insert education.
Yeah. I hear you, man. But I feel like no, I don't know why I'm like stuck in number at like 70%, whatever. I think it's because like I'm less cautious of it, and almost to a point where it sounds looks I don't want to say it's bad, but like, it's kind of like you're borderline, you're like pushing too much. Because trying to like, even with, like I said, like with the, recent ACL injury, and meniscus, like I'm like, oh, I gotta do this. But we know that you don't want to do that. You have to be super cautious about it. So,
I feel like also maybe thinking about it a little bit more. We do our own needs analysis. We do our testing, objective testing. But like I feel like because I mean, we're just a guide. We are literally walking with patients through this process. They do their own needs analysis. And I
Mhm.
think like it's one of the harder parts is just realizing like, yeah, not every patient who comes in for ACL rehab is also going to want to come in for 9 months because their goals are different. And that's been the tricky part. This is like this patient is one that their needs analysis is one that's going to require them to go through the full process of 9 to plus months of rehab. And I think they see that at like every day. And so it's like kind of tough to wrap your mind around it, but like it's like it's something that they're living with every day. And not just the 2 days a week when they come in the clinic. It's like
let me ask you this question. Emily. They got, based on what you said, they got full range of motion. I don't know when you last measured it. They got 70%, more than 70% on uninvolved side, like compared to right.
we're due
Uh,
for like another assessment. Like do another. We'll probably do like the crane scale again, test the
mm.
quads. But
To
we have to
me,
motion in a minute.
I almost like, if I saw this, I almost feel like this man's ready to like, do a lot of things. And some people like kind of you can start ramping things up. And even though it feels like it's not there yet, almost kind of like, is there like, to me, like they got the functional abilities, man. Like, when we talk about being functional, being able to participate in all their daily activities, they can do that without, I don't know the pain level, but they can do pretty much everything, right? And so sometimes right now, this is like kind of sweet spot that like I'm good. And some people decide to like not pursue more, but if they really want to return to sport, this is a good time to like ramp it up, like, is start to like really start to test waters. Like, what is your tolerance level? I say like, can you tolerate it? And if you can tolerate it, let's try it out and see how you feel,
Right.
and your body will tell you.
My other thoughts with that is too is like, hey, I do want to ramp it up. Every like thing that I see as far as like injury prevention, reducing risk for re-tear. So volleyball could be a risky sport. I mean, a lot of jumping. And it's not as much of a cutting sport as like get soccer or football, but like this is the sport that they had injured their knee in. So it's like, can we get them as strong as possible? And everything points to being like, all right, can we get them like to that 90% mark of knee strength? And that would be like my ideal done. Can we get there? Is that like in a bubble? Is that in like is that our discharge or are we gonna is something I don't know, at some point are they gonna want to just ramp it up? I don't know.
What you think, man?
Well, I mean, I think you just want to be a little cautious with like just differentiating like when we're dealing with a patient in pain, chronic pain, and like that mindset of like let's push them, let's encourage them, and then when you're dealing with like a structure specific, I guess more with the ACL, like there is a timeline that you want to respect, obviously. I mean, yeah, I mean, you can just kind of educate and be like, hey, you know what? Like, we have good data to support that. Like, if you go back to volleyball full go and with your ACL, with your quad at 70, you're going to be at increased risk to re-injury. You don't want to come back and see me, right? And then
I,
ultimately they do what they want, right? But you just, your job is just to kind of educate. And if they want to discharge, knowing that information, you're like, all right,
no,
respect.
I mean, like in terms of like ramping up the return to sports activities is what I mean. Like, not necessarily like, yo, good luck, dude. If you want to go back, or do it at
Yeah.
your own risk, kind of stuff like that. How do you feel about ramping things up now at 70%?
I mean, I think like running that's cool to go with running, and you're cool to kind of progress as taller with running. I don't know how comfortable I'd be with like cutting type stuff yet. I think you want that quad a little stronger to be doing like a really aggressive like plant change of direction, right? Just think about the amount of force that's going through there. You're getting there though. 70%, you're getting there. Like you're getting to the point where you can, and that was a month ago too. So maybe if he's closer to 80, then that changes some things. You can then start to ramp up.
Yeah. This is where I struggle a little bit because in my mind, I'm like, let's start, not like aggressively start ramping up, but start introducing what it feels like, to land. Like, because double limb supports are usually a lot more stronger than single limb. So like, let's start introducing what it feels like to land. Let's start introducing what it looks like the initial flight. Let's start introducing what it feels like to do, some basic ladder stuff, right? Even if that
Oh yeah,
means like just walking and things like that. Initial, and then to almost kind of make them feel psychologically prepared, you know? And like my ACL volleyball player too, like even though we're super early, we're not running, we're not doing nothing, right? Mostly focusing on neuromuscular kind of things like that. Even with that, I've kind of started to look, this is what ladder is, you know? This is what ladder is. This is how we would go through it. Let's walk it. We don't have to do nothing. Let's walk it.
I like that. Yeah.
Yeah. And so that I started doing that, but I know, but some people think that it's crazy because
Well, it's all
it's
about intensity, right? It's all about
yeah,
your intent. Yeah.
yeah. But I'm on the crazy spectrum though, so I don't know. Like
The wild man.
yeah.
Somebody
I'm
tame
not
that man. Somebody tame him.
I'm gonna get in trouble one of these days. Because I have kind of even the phrase where I used to say like do what's tolerable. Like even I think that could be very subjective. Is like some people will be like, yeah, this is very much tolerable. And then they
Oh
struggle.
yeah, for sure.
Yeah. All right, Anthony. What do you think?
What do I think?
Yeah.
Yeah. Did you
Tolerable
have any more
or
questions or?
all right, I got one more, and this will be it. So this is a patient who's been very motivated, and they want to come in like so. If it's just somebody that wants to come in for 2 times a week, they get into the 7 to 8 week point. Like I think they can be independent. I think that they could get. I think that there's a lot of resources that they could kind of dig into on their own, or that we could talk about sharing. But like, do you think it's? What are your thoughts on almost referring a patient out for like strength and conditioning, like working with the strength coach? Because I don't have any great relationships in the area for strength coaches, but if this is a patient that wants to kind of build up on that confidence, get back into sport, and like obviously we can make the space work, we can make our resources work, but could we maximize their recovery rehab process by saying, hey, maybe you come here once a week or once a week and go there once a week, or we say at some point, I think we should try doing this.
Cost would be the main priority for me. If that's not a factor, and you have a good relationship with a strength coach, sure. But I'm like, those are things that you could do at the gym, and then let them explore. Because that's another thing, like in terms of independence. Because I know, like, I remember when I first went to the gym, it was very intimidating. It was very intimidating, and you get comfortable by being in this uncomfortable zone, right? And trying things out. So might as well start introduce, because like the goal is not to rely on people. At least goal is to do things. So I would just start introducing things like there's if they already start doing single squats, split squats and things like that, man, you got like weights, start showing them what squats it looks like, what all this exercises that you're trying to do, start introducing how you can transition into gym. I would do that at the gym. I don't know why spend time, um, but I know.
Yeah, that's a good question. I mean, I guess it kind of depends on your expertise. If you're like comfortable writing a program for somebody, but also like that's time out of your day that you're not going to be compensated to write a kick-ass program for somebody. And like, yeah, we right, we're maybe called to do that, I guess. But like that's tough for everybody, just from a us perspective and wellness perspective on our part. But yeah, I mean, that's where it would be helpful to have a close relationship with a really solid strength coach after you, right? That's where your done would be different, your finish point. But like if you have access to that, that would be super useful, obviously. They'd be like, yeah, just go see so and so, and they're gonna crush you. We're gonna check in like every 2, 3, 4 weeks just to measure your strength and outline like your education like progressions.
Yeah. Uh, it's so funny. It's like there's so many roles in PT because, like, yeah, I would love to just write these programs for my patients and just have like, I want to do
Man,
this.
man,
Like,
man,
it's
do
hard to
it.
out. I know.
Just do it.
Yeah, it's tough because with the busy schedule, yeah, it makes it harder. And then like the patient has a
Well,
motivation
it's cool, man. You
now.
got to do notes too, right? You got to think of it from
Yeah.
our perspective. Like, how is
But
that
it doesn't
sustainable? Is that
it,
sustainable?
it doesn't need to be perfect. It
Mhm.
doesn't need to
No,
be
it
perfect.
doesn't.
You just have to guide them. Normally what I say is, when I'm trying to get people to go to the gym, is, well, just show up, right? Just show up, and think about how your joint moves, and do a lightweight where your joint moves, and see, explore things around. If you're getting uncomfortable, there are a bunch of machines there. Use the machines before going on free weights. And once
Right.
and they at least by showing up and doing things, and they tell me that, oh, I did this and all this stuff, and I was like, cool, let me show you something that you could actually try it out and see how you feel, and we can practice it here and then go over there. From that, like, you can just kind of guide them through it. And so I think you could do it. It doesn't take a whole lot. I know,
Yeah.
trying to write a perfect program, which I don't think I know how to do it. I got a question for you guys after, but um it's to promote, push you, give it a little bit of nudge, like, you need. And so,
Mhm.
like, I don't, Matt, let me ask you this. How many years did you train with a generic plan before you go, start building something for yourself?
You mean like how many years did I not follow like a structured program? Just
Exactly.
flounder
Just
around like a
flatter,
fish in a
yeah.
gym?
Yeah.
Yeah, man. I mean, that was
Even now,
most of my high school. I mean, honestly, now I'll follow a structured program every once in a while, but like I just
right?
go in there and get after it. Follow a generally progressive overload principle. Um, but also right up, my training age is different than somebody just getting started. But
Right.
yeah, and I like what you're saying.
Would
Yeah.
what would you say? What is more important to you? someone going and exploring things, or having a perfect structural program?
I think it depends on their goals, right? Again, if we're talking about a chronic pain patient who we just want to get them exercising, trying to strive to get a little closer to physical activity guidelines, perfect. I'm not going to write much. I could, but I don't. You don't feel need to write a perfectly structured program. Again, for a dude whose goals are fairly high, you're going to want to see at least there's going to be like minimums that you're going to need to meet, and it's going to be like, all right, dude, you're going to be doing leg extensions. Like you can go and mess around the gym and explore your movements, but you definitely want to be doing leg extensions, progressively loading, and you're going to want to be doing other quadricep type exercises, and then also like plyo progressions. Generally, you want to like maybe outline that. Um, I guess that's what I would say.
I'd want them to get in there just to explore, like show that they have that motivation and like the willingness to do it on their own.
Yeah.
If I could say one thing, and this may be the last thing I'd think, if I could have a patient go from 70%, all right, call that knee strength, and say that's the end point, but they were ready to go and do things on their own to like um, go getting in the gym, have the skills and kind of the knowledge to be able to like continue strengthening, like programming for themselves or knowing how to get there, versus having a patient be at 90% but not know how to handle strengthening afterwards, like the long term management that way. I don't know. I think I would probably lean towards that like 70%, which I'm not encouraging patients to be discharged at 70%, but like
Claim.
No,
I do think there's that thought of like, yeah, we got to get them ready for still after they're not with us.
yeah. I I'm there, man. Like I think like I feel like even now I got a structured program. I just show up, and I know like basic fundamentals of like uh progressive progressive loading, right? And just kind of keeping an idea, like monitoring, and don't do more than what you can't tolerate, like initially. That's it. That's really it.
But that
Um,
sounds good.
I do got a question though. Like I know Matt, I feel like Matt, you would have a more more to say this on this one, but how do you feel about us physical therapists like lacking the ability to write at least have an idea what strength and conditioning is, lacking the ability to properly write a good program. But I know in reality, when we see mostly, oh, back pain, everyone's coming with back pain, it doesn't really matter because it's like very generic
Yeah.
population. But at the very least, I feel like we should have the knowledge to do that, and everyone should be in the same page because
Yeah.
we're historically known to underload patients.
Yeah.
And
Yeah. I mean, that's an issue that a lot of people are aware of and talking about is, yeah, I mean, the curriculum's great at making us safe and aware of, medical conditions and stuff. But yeah, it definitely didn't prepare us to write really kick-ass strength and conditioning programs for higher level patients. So that's where I guess continuing ed comes in, right? If you're going to be a sports PT or a PT who's treating a good amount of return to sport people, you should take continuing ed courses. There's a lot of good stuff out there, right? With that can equip you to get that knowledge. But it's important for sure.
Anthony, how do you feel?
Yeah, no, I agree. What Matt said. uh, I definitely didn't start like exploring kind of like the athletic dimension of physical therapy, or just like I like to run, but I did not like think about like how dynamic we are and like how resilient our body is, that like we are strong and that like I think that I don't know, it's not something that we're all ingrained in. It's not ingrained in every culture. So PT can
Yeah.
move in that direction. I think that programming for all needs is important, and yeah, we need more of it.
I will tell you this, bro. Like genuinely, like if I wasn't involved or like if I didn't have a right group of people, right mindset, like the people going through a PT school, I don't think my mindset the way it is right now would be like this. I maybe just may have been one of those followers, you know? Be like, oh, do some TLCs, do some massage, this is what physical therapy. Oh, you got anterior
Kubosh, the
pelvic
dry
tilt.
needling expert.
Yeah, but I don't know. I don't know. That could have been a whole different, and that is what
Adam
is.
Meakin's got a hold of you.
Yeah, jeez. But no, I don't know. Maybe I would eventually would have converted.
We
Yeah,
did come
yeah.
from a pretty decent background, I will say. While we didn't have a strength program in our physical therapy, like education, I think we had some pretty good mentors, and like I think as peers, we've been great. It's good, but like because we went through like I don't know, I'd say Springfield College, it has a pretty big athletic mindset. I think that we've gained a little bit from. I would say like I've learned a lot from that.
But who knows, man? In 20 years, maybe this is all fake news.
Yeah.
Yeah. Anyway, I don't know.
Yeah.
Yeah, Anthony, do you have any more other questions that you want to add? I think, dude, what you're doing is great. I don't know why I'm stuck in the numbers, but obviously it's especially post-op ACL, return to sport. It's better to be cautious than be aggressive. So
No. No. No other questions. Say it's good to talk about it, even though there's a lot of jargon and kind of language and
Yo, I have one thought, Randy. I think you could throw some interval training at this man. Because you said
yeah.
like you laid out that like volleyball is like a on off. Where I've like only watched a few volleyball games, but yeah, it is. It's like longest duration, right? You said like a 20-minute match or games within a match, 20 minutes, and then it's on off. So like you could probably have him like on the bike, just like going ham for like 30 seconds, a 30-30, whatever ratio you want to do, or like a ski erg, or like um, a rowing machine. I mean, probably not running, obviously yet, but
We could do that. The
I
program that
think
we
I'll do a
have
light
going,
jog.
yeah, we could do tracking. But we had the program that we got going at home for this patient. Like, yeah, no, we could tie a couple of those into a superset and just say, hey, like, I want you to go into each of these rounds with a little less rest than you do because we're trying to work towards that goal of getting back to sport where you're not going to be resting every single time. I like that. Cool. No,
All
that's
right.
it.
Thank you for listening. This is our second episode or video, whatever we want to call it. This is a case study, our first case study of 20 to 30 years old, status post ACL reconstructions, volleyball player.
happy
Thank you for
Thanksgiving.
listening. Happy Thanksgiving.